To examine the whole upper limb is an artificial thing to do. One of the closest things that would parallel that is a patient in whom you suspect Parsonage-Turner syndrome, brachial plexitis. They come with pain that lasts a couple of days and then say, oh, my arm feels a bit weak. And so you have to do a complete upper limb examination in order to determine what has been affected and what the outcome is. And so that's the first part of what we'll do. And I commence by doing an examination of sensation using dermatomes. So can you feel this, or tell me where it feels abnormal? That's C4, C5, C6 down the lateral border of the arm, dorsum of the hand, C7 traditionally index and middle finger, C8 ring and little finger, medial border of the arm, up T1, intercostal brachial T2 in the axilla. If there's no particular note of or where the sensory change is, or for example David says, oh, it feels a bit odd here, I'll then go through and do a cutaneous sensibility examination based on the peripheral nerves. So supraclavicular nerve over the clavicle, down onto the level of the chest, up to the nipple line, axillary nerve in the epaulette area, that's C5, musculocutaneous nerve in C6, remember that's the continuation, lateral cutaneous nerve, so you feel the lateral border of the hand, of the forearm, and the dorsum of the hand, also supplied by superficial radial nerve, C7. Median nerve, you know, ulnar nerve, you know. Discriminate between levels of injury by determining whether the palmar branches are affected or whether the dorsal branch is affected, because that branch comes off proximal to the wrist. Medial cutaneous nerve of forearm, medial cutaneous nerve of arm. And so by that you can determine whether there's a problem with a dermatome or with a named nerve. You then come on to motor examination, and we want to start very proximally with accessory nerve to trapezius. Shoulder shrugging is what's usually described for trapezius, shrug your shoulders, but the trouble is that only tests cervical fibers and not the dorsal fibers. So the way to in fact test trapezius is to get the patient to abduct the arm, and they have trouble abducting if trapezius is not functioning, because trapezius helps to stabilize the scapula. If they can abduct the arm because they can use their accessory muscles, you'll see that the medial angle of the scapula becomes very prominent in the supraclavicular fossa, because the scapula malrotates, and so the medial angle comes up here. And if you want to exaggerate the effect, you then push down on their arm and they'll demonstrate it. Then coming on to the upper branches of C5, C6, which is suprascapular nerve, so supra and infraspinatus initiate abduction, lifting the arm up, and also do external rotation. Now, lifting the arm up is a compound movement with supraspinatus and deltoid. So if you want to isolate the function of the suprascapular nerve, go for external rotation. So you have the patient with the arm by their side and get them to externally rotate against your hand. You can see how far they can externally rotate. That gives you an idea of range. And then you can get them to push against your hand, and that gives you active external rotation, infraspinatus function. So you can tell whether that's gone. You can test whether the long thoracic nerve, also 5-6, has been affected. It's commonly affected from Parsonage-Turner, getting them to push against your hand and observing for scapular winging at the back or an inability to perform that action. So that's long thoracic nerve. And you can do dorsal scapular nerve by getting them to bunch their scapula together and get them to retract their shoulders. So then the next nerve is musculocutaneous nerve, which we assess by doing elbow flexion. As you remember from the last couple of days, there are lots of things that flex your elbow. So you can't just flex the elbow and assess and say that musculocutaneous nerve is adequate because of that, but you actually have to palpate biceps when you do it and make sure they're not cheating by using elbow flexion, by using wrist flexion, for example, in order to create elbow flexion. So feel the biceps, assess the power by pushing up like that, and that will tell you whether the musculocutaneous nerve has been affected. Median nerve, a compound nerve, we assess by getting wrist flexion and then the anterior interosseous nerve by flexing the thumb and index finger, so they can make either an O sign, or rather than do an O sign, which might be affected also in ulnar nerve palsy, I just get them to flex the FPL, test power, flex FDP, test power, test FDSs, that's also median nerve innervated, and FDPs of the index and middle can be tested separately as well. So, and the final thing that you can test is pronator. So get them in a supinator position, get them to pronate against your hand, and then you can feel it and see it and feel the function of pronator. We can go back up to the radial and axillary nerve. Axillary nerve sensibility we've done. It supplies deltoid and also teres minor. Can't really test teres minor, although you can palpate it. Deltoid is best tested by palpation, because there are other things that abduct the arm, but you can see here when David's abducting his arm under tension, that the anterior fibers are contracting as well as the middle fibers, and you can get them to extend in an abducted position and against resistance, and you can feel the posterior fibers for that. Radial nerve supplies triceps. Triceps you test by getting them to push down against your arm. Supplies the mobile wad before the elbow, so brachyradialis function is tested by elbow flexion in a mid-pronosupination position. You can see the contraction of brachyradialis as it contracts there, and that's a very good C6 marker as well for brachial plexus examination. The ECRL and ECRB can be assessed by wrist extension against resistance, finger extension, of course, and independent thumb extension, making them to make a fist, make sure the extensor indicis and extensor digiti minimi are also functioning. And then, of course, the remaining nerve is the ulnar nerve. So I get them to test, I start off with finger abduction, get them to test abduction. As you'll remember, no point testing little finger abduction because the extensor digiti minimi overcomes any absence of palsy, or absence of function in the abductor digiti minimi. So you need to test against the ring finger, and then get them to cross their fingers or pinch, and then test the thumb against the index finger. We'll go through the ulnar nerve signs in a little bit. And so that's sort of a global brachial plexus examination that tells you where the lesions may lie. And in a parsonage-Turner sort of syndrome, commonly they have some altered sensibility in the lateral cutaneous nerve of forearm, and picked off some nerves that are dysfunctional, usually suprascapular nerve, long thoracic nerve, and occasionally anterior interosseous nerve to thumb and index finger. The other thing I wanted to point out was, because it's quite common that people have to do a shoulder injection for rotator cuff syndrome, and that's on this surface. I'm just going to get you to turn your back a little bit here. The posterior angle of the acromion can be palpated, and about 1 centimetre down and medial, there's a little palpable depression, and that's the point in which you put your needle, and then aim for either the coracoid or the heart, and then make sure your needle's not too long. Push it up to the hub, and you'll be able to inject into the joint and put the steroid in it. So that's a surface marker for a shoulder joint injection. Just moving down from the shoulder joint to the elbow, lateral elbow pain, differential, is lateral epicondylitis, a radial head problem or a problem with the radial capitellar joint, or radial tunnel syndrome. And to distinguish them, you can palpate the lateral epicondyle. If you have lateral epicondylitis, it'll be tender on the lateral epicondyle and 1 centimetre distal. So you press on the lateral epicondyle. If that's the point of maximum tenderness, then that's indicative of lateral epicondylitis. If the tenderness is a bit more distal and it sits on the radial head, which you can check by pronosupination, or it gets exacerbated by pronosupination whilst you put pressure on it, or by loading the radiocapitellar joint by pushing down on the radius and then rotating and then palpating it, then that would be indicative of a radial head problem. Whereas a radial tunnel syndrome problem has has tenderness over the posterior interosseous nerve as it comes through supinator, and as you've seen from your dissections, that's not around the neck of the radius, but about an inch further more distally, about here. And if that's the site of maximum tenderness, then that is radial tunnel syndrome. The other provocative test that you can do for lateral epicondylitis is flex the wrist and get them to extend against resistance. That tenses up extensor carpi radialis longus and brevis, which insert on here, and that pain will be exacerbated. You can do the same thing with middle finger extensor, so you flex the wrist, flex the middle finger, get them to extend against resistance, try and straighten your finger, middle finger, thanks. And again, the origin of the extensor digitorum communis, particularly the middle finger, you can feel it tighten here, is right on the lateral epicondyle. So if that becomes painful, that's lateral epicondylitis. This middle finger extension test against resistance is actually also used for wrist problems, radial tunnel syndrome, so it's a fairly nondescript test, except for where it localizes to the symptoms. So if you do this test, hold your middle finger straight, push down, and they go, oh, my pain is here, it's clearly not radial tunnel syndrome, they've got some sort of central wrist problem, generally. If you suspect it is radial tunnel syndrome, then the radial tunnel can be provoked by tightening supinator, by putting the patient in full pronation and then getting them to and then just going to extend the elbow because that also tightens it a little bit more, and then get them to try and activate supinator by trying to supinate against resistance, and that may make the symptoms worse. Putting them also into supination, into full pronation tightens up the leash of Henry, and then so that can also be a provoker of symptoms. So that's radial tunnel syndrome. On the other side of the elbow, of course, there's medial epicondylitis or golfer's elbow, and that's tenderness over the medial epicondyle or just slightly more distal at the site of origin of one of the heads of flexor carpi ulnaris or deeper flexor digitorum profundus, particularly that of the little finger. On the other side of that, of course, is the immediate nerve on the deep and lateral aspect. The other differential for medial elbow pain is ulnar nerve compression or irritation, or a snapping ulnar nerve or a subluxing ulnar nerve that tries to escape out of the hollow. And I was going to go through the ulnar nerve signs. They're postural signs where you look at the hand. The shape of the hand should have a concavity. If the palm is flat or narrowed, then that's called Massey's flat palm. You look to see whether or not they have an abducted little finger, Wartenberg's sign. You look to see whether they have a claw, Duchenne's claw. You look to see whether they have a hyperextension of the metacarpophalangeal joints in order to accommodate the claw. That's Manifeld's hyperextension. You look to see whether they've got a collapsed deformity of the thumb due to loss of flexor pulsus brevis, so they end up with a hyperextension of the metacarpophalangeal joint. Obviously, look for atrophy of the hypothenar muscles, guttering on the dorsum of the hand. The thumb signs are Frohman's sign, either with a bit of paper, or I don't bother with a bit of paper, but get them to pinch the thumb against the side of the index finger. And if they can't adduct properly but use their FPL to accommodate for that, that's a positive Frohman sign. If they do that and their thumb metacarpal also subluxes like that, that's Jean's sign. It looks like a J. So that's how you remember Jean's sign. Frohman's everyone remembers. There's Bonnell's scrape test, where you ask the patient to run their thumb across the palm of the hand, and in an ulnar nerve palsy, they're unable to keep the thumb across the palm of the hand, but it lifts away from the palm due to the shape of the joint, and they've lost an adductor. There's Bonnell's O sign, also used for anterior interosseous nerve palsy, which is why it's slightly confusing. But in ulnar nerve palsy, you're unable to make an O because of the loss of the adductor, and so the O collapses into that sort of shape. The finger signs are the ability to abduct and adduct the middle finger from side to side. And the problem with that, so that's Picture's test 2, sign. The second of the two signs he described for ulnar nerve palsy. The other one was the narrowness of the palm. The problem is that you are able to compensate for the loss of interossei to move your finger from side to side using your extensor tendons. And so to overcome that, you can get the patient to flex their finger and then wiggle it from side to side. This is a coordination challenge, particularly in explaining to the patient what you want to do. But this sign was described by Igawa, and it explains, it takes out the long extensors so that you are purely using your interossei to move from side to side. A much easier test is to ask the patient to cross their fingers, because that does that, and there's nothing really that you can cheat with finger crossing. The abduction, I explained earlier, I test like that, or I get them to pinch my finger in addition. It gives me a sense of how much power they have in adduction in addition to getting them just to cross their fingers. I also get them to just spread your fingers apart. You could see here where David is abducting his little finger against resistance, that he has dimpling along the palmar aspect of his palm due to the insertion of palmaris brevis onto the skin. So that's called Mumenthaler's sign. And you also get Ollier's sign, where somebody abducts their fingers and you get against resistance. They get, I'm going to just extend your arm a bit for the camera so you can see it, just abduct your fingers. You can see dimpling that occurs at the entrance of Guillaume's canal due to the pull of flexicarpi ulnaris, so it's Ollier's dimpling, Ollier's sign. You remember that Ollier's phenomenon is how you find Guillaume's canal by pushing on the hypothenar mass and watching the fat come down Guillaume's canal into the distal forearm. You then test the long flexors because you want to discriminate whether there is a motor problem proximally up the forearm. So I get them to grip my fingers, and then gripping my fingers like this, I can test each FDP separately. And if they have a weak FDP, that's Pollock's sign. You remember it because having a weak little finger is bollocks. And of course, you then do flexicarpi ulnaris, ulnar deviation, slight bit of wrist flexion. It's very hard. You can cheat by doing with other muscles that can do that. So you make sure you feel FCU whilst you're doing that. So that's the ulnar nerve sign. And you remember that the compression that can occur at the arcade of Struthers up here, medial triceps and intermuscular septum, the cubital tunnel, the two heads of FCU, and the Mardiot's fascia. And so you palpate all of those and find out whether the nerve is tender at those areas. And you can do Tunnell's-Hoffmann test at those areas. The provocative test for the ulnar nerve is the flexed elbow test. So you put your fingers over the cubital tunnel with some gentle pressure, flex the elbow because that tensions the ulnar nerve around the elbow, and then extend the wrist and hold it like that. No more than 30 seconds. It should provoke symptoms. If it doesn't, then it's not positive. At the same time, whilst you're there, you assess for subluxation of the ulnar nerve, so you keep your finger on the medial epicondyle and you flex and extend the arm and feel whether the ulnar nerve tries to jump out of its groove. If it jumps out of its groove and you want to assess whether the triceps is responsible, then you do the same thing with one finger on the medial epicondyle, one finger on the triceps, and get them to extend, to push against my hand, and feel whether the triceps, when it contracts, pushes the ulnar nerve in front of the medial or on top of the medial epicondyle. The provocative tests for the median nerve, if you suspect pronator syndrome up here, you remember the median nerve goes under the arch between the two heads of pronator and then just distal to that through FDS. Those are tensioned by putting the arm into supination, which makes them tight. You then tension pronator, just extend the arm, that makes it even tighter. Get them to activate pronator by getting them to pronate against resistance, and then you palpate on top of the nerve as well, and if they go, that's painful, like it is in everybody, they've got pronator syndrome. No, I'm joking. So that's pronator syndrome. For FDS arch, if that's caused as a pronator syndrome or the proximal median neuropathy, then I will tighten the FDSs by, again, putting the hand into full supination, extend the wrist, extend the fingers, flex the middle finger, and flex that against resistance. And that will tighten the FDS all the way up here, tighten the arch, and that might compress the median nerve. If you want to increase the pressure on it, then you put some digital pressure in that spot as well. The provocative tests, down at the wrist, Phelan's and Durkin's test, often combined. Good. Let's do radial-sided wrist pain. You have to differentiate from Wartenberg syndrome, where the superficial radial nerve comes out from undercover of brachyradialis, causing neuritis and pain here. They would frequently have a positive Tinel test over the superficial radial nerve as it emerges there, and a point of tenderness. The other differential is de Quervain's, tenus synovitis. It may be easy if you have a patch of redness, erythema, or swelling in this area. If not, there is the well-described Finkelstein's test, where you hold the thumb down and radially and ulnar deviate the wrist. In fact, most people do it by getting the patient to hold the fingers around the thumb and then radially and ulnar deviating the wrist, and that provokes symptoms. This, in fact, is Eichhoff's test. Finkelstein described it where the examiner holds the wrist and does that. But both of them are provocative of pain and tenderness here. If you then want to decide whether people have more than one compartment, or you can do it by injecting steroid and local anesthetic into the compartment and seeing whether it blocks both, and then retest them and see whether it blocks all symptoms or not. Or the other way is to say, right, which particular tendon is most inflamed? I can take the tension off abductor pollicis longus by abducting the thumb. That will take tension off APL, flex the metacarpophalangeal joint, and you can get the patient to extend at the MCP joint. Now, if that causes symptoms, then it's more likely to be an EPB problem than an APL problem. So other causes of radial-sided wrist pain, radioscaphoid arthritis, crepitus pain, radioscapholaniac dissociation, basal joint arthritis. So I'm going to jump to basal joint arthritis and then come back to the wrist. Basal joint arthritis, the provocative tests, as you know, are the grind test, where you compress the metacarpal against the trapezium, or the subluxation relocation or shift test, where you grab the finger, have your thumb on the base of the metacarpal, and you relocate it by pushing down and also extending the thumb. And that is painful. The other causes of radial-sided wrist pain, like a ganglion, is fairly obvious. A neuroma or neuritis, you'll test by sensory distribution. But the other common one is radioscaphoid arthritis or scapholiniac dissociation. Radioscaphoid arthritis, there will be much more swelling generally, a history of trauma, a bad X-ray. But I examine the wrist by having them in a neutral position initially, palpating from the scaphoid tubercle and then the palmar side of the radiocarpal joint, moving around onto the radial styloid, have them now shifted slightly into ulnar deviation so that you can feel the radial styloid step up to the snuff box and then up again onto the trapezium into the basal joint, looking for points of tenderness, swelling, pain, or when you're moving the wrist around, crepitus. Keep moving around, feeling the radiocarpal joint as you come around, feel the Lister's tubercle. Distal to that is the, can't find your Lister's tubercle. Okay, Lister's tubercle. Distal to that is the scapholunate ligament, and then the little depression that you can feel there, which is the lunate, and then the capitate head. And you're feeling for tenderness, coming around, feeling the radiocarpal joint, distal radioulnar joint, and then shifting the hand into radial deviation, the ulnar carpal joint. I'll come back to the distal radial ulnar joint and ulnar carpal joint because we're concentrating on the radial side at the moment. But if you've detected nothing so far, you want to determine whether or not there's any instability of the scaphoid. We'll do the scaphoid shift test. Rest the elbow on the table. Index finger goes on the scaphoid tubercle. The thumb goes on the back of the wrist and Lister's tubercle, so that the pulp or the base of the distal phalanx is resting on Lister's tubercle, and the pulp of the thumb overhangs the radial carpal joint so that the tip of the thumb is feeling the head of the scaphoid. It's just like that. This index finger is pushing hard on the scaphoid tubercle to prevent it from flexing as I move the wrist from ulnar deviation to radial deviation. So as I move from ulnar deviation to radial deviation, in this intact wrist, my finger, you see here, gets pushed forward anteriorly. If there is a scapholunate dissociation, I can prevent the scaphoid pushing forward against my finger, and instead the scaphoid will stay extended, but as it tries to clear out of the joint to make space as it radially deviates, the proximal pole of the scaphoid, or the back of it, will push against my thumb, and it starts to slide out of joint until such time as it engages with the lunate and capitate and it clunks back into position, and you get your one chance at doing the examination, so make sure everyone sees it when you do it, and you pick up the clunk because it's painful. So that's Watson's scaphoid shift test. You can, if you perceive some instability, try and do a ballottement test where you hold the lunate between your thumb and index finger in the center of the wrist, hold the scaphoid, and then see if you can move them separately like that. But that's not always easy to do. You can do the same thing for the lunotriquetral joint if there's ulnar-sided wrist pain or central pain, to do that. Central wrist pain, usually occult ganglion, arthritis, or Kienbock's disease, and there's tenderness in the center of the wrist like this, and the middle finger extension test that we talked about earlier on will be positive. The other cause of central or global wrist pain is midcarpal instability, where you distract the wrist, make sure they're nice and relaxed, and then you wobble the wrist and the one way and the radius and forearm the other, radius and ulnar and the forearm the other way, and you assess how unstable or how much movement or clicking or clunking there is, and then if there is instability, and it's often normal in young women, for example, you can then see how unstable they are by moving them from radius and ulnar deviation with some load, and then you'll often get a clunking wrist just because of the increased laxity of the ligaments in between the carpal bones. And of course the other causes of radial-sided wrist pain are tendinitis. So flexor carpi radialis tendinitis you assess by putting the wrist into extension, ulnar deviation, get the patient to flex against resistance, palpate FCR, and it will be tender. Or intersection syndrome in the second compartment, where you flex the wrist to extend the tendons, and then get them to extend against resistance, and then palpate and feel that. Good carpal boss. Intersection syndrome is second compartment stenosing tenovaginitis. It's not caused by the passage of the APL and EPB over the ECRL and ECRB over here. Some people do get a compartmental syndrome within those muscles, particularly if kayakers, for example, people who do lots of extension and flexion of their wrist, or rowers. But that's a separate condition, it's not intersection syndrome. Ulnar-sided wrist pain is ECU, it can be the same thing as at the other side, ECU tendinitis. Again, same thing. For tendinitis, you put the tendon under maximum tension, then get the patient to extend the wrist. Now you remember that in a pronated position, the ECU in fact is not a wrist extender, it's an ulnar deviator. So ECU is here, so getting someone to extend their wrist like this probably won't provoke it very much. So you get them to extend it, put them into supination, and then lift their, stretch the tendon, and then say, right, push down against my hand, and that will be tender, because that now it is a true wrist extender. In this direction, it's an ulnar deviator. Of course, distal radial ulnar joint instability. So you can either see it because the hand is hanging off the wrist, and so the ulnar head becomes prominent, or you can test it by ulnar ballottement or the piano key sign, where you push down on the ulnar and it naturally rises back up by itself, but only a limited amount. And if this degree of travel between the ulnar and the rest of the hand and radius is too great, then there's some instability. If you assess some ulnar instability, then you can test it further, again by putting the hand, resting it on the elbow, having the hand, first of all, in neutral pronosupination, put them into ulnar deviation, so you're supporting the radius in your palm and the hand, and then with your other hand you're holding the neck of the ulna and then moving it from side to side. Now you can then detension the ulnar collateral ligament by taking it off radial deviation, so putting it more into ulnar deviation and seeing whether that becomes more unstable. Now you'll see that is more unstable there than if I ulnar deviate it where it becomes tight. Sorry, radially deviate it and it becomes tight. So if I ulnar deviate, take the tension off, that wriggles. If I tighten it, it doesn't wriggle. Now, sometimes you tighten it and it still wriggles, so that tells you something about the stability of the ulnar head. You can then change the relative position of the ulnar head and the radius by putting the hand into supination and then reassess, or pronation and reassess, and that will tell you the relative stability of the palmar radial ulnar ligament or the dorsal radial ulnar ligament. You can also, as I said, do the lunar triquetral ballottement test. You can assess abutment of the triquetrum and lunate on the ulnar head or the TFCC by putting the hand into ulnar deviation, pushing down so there's axial force, and then rotating and seeing whether or not that provokes symptoms, and then assess it again in palmar deviation or extension, as that puts stress on varying different parts of the ulnar joint. The pisotriquetral arthritis you assess by holding the pisiform in your hand, pushing it down against our triquetrum and eliciting a grind or pain. And of course, an additional source of ulnar side wrist pain is ulnar neuritis or irritation of the dorsal ulnar nerve branch or the true ulnar nerve itself, which we've already learned to examine. So, some of the tests for extensor mechanism, you can just do the normal tenodesis test, so you can see whether or not the fingers extend when you put the patient into wrist extension or flexion. So this is also another sign for ulnar nerve. If you notice someone who you think has an ulnar nerve palsy, who has limited IPJ flexion, what they will tend to do when they try to extend their fingers is automatically drop into wrist flexion. It's called Andre Thomas's sign, and they drop into wrist flexion in order to try and extend their fingers more. They usually can't because of their Duchenne claw. But you can, if you block the metacarpophalangeal joint hyperextension and then get them to use their long extensors, then they often can extend the digits. It's called the Bouvier maneuver. So you have someone who's got difficulty with extension. You want to determine whether or not their central slips ruptured because they were playing rugby and now they have trouble straightening out with their finger. You can put the extensor mechanism under tension. So flex the wrist, extend the metacarpal, and then put pressure on the middle phalanx to see whether or not you can easily or otherwise flex the PIP joint. So with a tight extensor that runs all the way down here, then the passive flexion of the PIP joint is limited, whereas in a Boutonniere deformity or someone who's got a rupture here, it becomes much easier. It's called Carducci's. So you then want to assess whether or not it really is gone, and there's a test, an early test called Elson's test, which, if the central slip's pulled off here, means that when someone tries to extend the finger, the central slip can in fact be pulled up towards the body, and that will in turn pull the lateral bands and make the DIP joint tight. So the test is put the finger over the corner of the table and get somebody to extend their middle phalanx against the digit, and in a normal finger, the DIP joint should remain loose. In a Boutonniere finger, the tension pulls on the lateral bands instead of the central slip, and the DIP joint becomes tight. Another way to test it is to get the patient to put both fingers against each other like this. Okay, so the middle fingers are the effect. It's also a test of patient coordination. So the middle fingers are against each other, and you get them to push the middle phalanges together to try and extend them. And let's just extend your flex your PIP joints. Yeah, PIP joints are flexed. The middle phalanges are pushing on each other, so the extensor tendons are trying to straighten the PIP joints, and you can see here that David's DIP joints are loose. There's no contact between the nails. In the affected finger, what will happen is on the affected side, the lateral bands will pull and the DIP joint will straighten, and that tells you that there's a deficiency of the central slip. The other test is a test of the integrity of the oblique retinacular ligament, so it's an intrinsic test. So essentially, the oblique retinacular ligament is loose when you flex the PIP joint, and that allows you to then flex the DIP joint. If it becomes, so then when you extend the DIP joint, the PIP joint, it should become tighter here. But not so tight that in the normal finger you can actively flex the DIP joint down or passively flex it down. Now this action of testing the degree of DIP joint flexion with different positions of the PIP joint, if you do it actively, so now try and bend it down, it's called Boy's test. So if this is limited, or there is no flexion here, that's a positive Boy's test. Or if you do it passively, where I try and bend it down, it's called Haynes-Zancoli test. And what it tells you is that the deficiency in the Boutonniere deformity, which you get the Boutonniere deformity like that, the oblique retinacular ligament has had time to tighten so that you can't then extend the PIP joint and then passively flex the DIP joint. I neglected, when I was progressing down the hand, to demonstrate the Bonnell or Finocchietto intrinsic test, which assesses the tightness of the intrinsic muscles at the metacarpophalangeal joint and PIP joint, and so that's the degree of flexion of the PIP joint that you can get relative to the position of the MCP joint. So in tight intrinsics, when your MCP is flexed, the intrinsics are loosened and you can flex the PIP easily, but as you extend the MCP joint and you tighten the intrinsics, it may prove difficult to flex the PIP joint, and that's a positive Bonnell or Finocchietto test. Good. If you have an inability to extend at the metacarpophalangeal joint, you sometimes need to determine whether there is a nerve palsy, a tendon rupture, or a sagittal band rupture that's allowed the tendon to sublux to the other side, or they have a locked MCP joint. Obviously, if you can passively move the MCP joint, it's not a locked MCP joint. If you can get them to extend if you can get a tenodesis effect, then the tendon must be intact. But it might still have a sagittal band rupture. If you want to assess whether they have a sagittal band rupture, A, you can see it, but B, you can passively extend the finger, then say, right, hold it there, and if they can then hold it there, then you know that the muscular tendinous unit is fine, and that it's a mechanical problem that once they flex, the tendon drops into the valley and they're unable to initiate extension. So that's how you distinguish between those. So, I mean, the common vascular test everyone knows is Allen's test. That's the one where you occlude the radial and ulnar artery, squeeze the hand, open the hand is white, you let one vessel go, the hand doesn't go pink, the vessel's not there, and then you let the other vessel go and repeat it on the other side. It's actually quite easy to get a false positive with this test, because if you squeeze the wrist hard enough, you'll occlude flow in the other vessel. So I can show you that David's radial pulse doesn't work. Oh, well, okay, I can't show you. Sometimes I can show you. Anyway, and you can do the same test down in the finger with the digital arteries, but that's Allen's test. So these are the tests for thoracic outlet syndrome. Most are vascular, not all of them. But so the first test is Wright's test, where you get the patient to hyperabduct or extend the arm like this, I've got my finger on the patient's radial pulse. I hyperabduct the arm. It's like putting your arm up when you know the right answer. In fact, it was described by Colonel Wright, but it doesn't matter. And the pulse goes. The problem is this pulse goes in 25% of fit, buff men. And then Adson's test is AD duct for add. Again, fingers on the pulse. Sun, Adson. The sun bit is you look up at the sun and you stretch the scalene. The scalenes go from the lateral tubercles of the spine onto the anterior aspect of the ribs. So to stretch it, you look towards the examiner, and that's the same as stretching the sternomastoid. So you look up at the Adson, adduct the arm, look up at the sun, stretch the scalene. To exacerbate the stretch, you ask the patient to take a big breath in, and you hold it, and you put a little bit of downward pressure on the shoulder, and you feel for the pulse. And the pulse diminishes in a positive test, or the patient gets symptoms. Reverse Adson's test is to put the chin not down at the sun, but looking at the chest down here, where you're trying to shorten the scalene, so you're getting them to contract up. So this is positive in swimmers, rugby players, for example. So the same thing, hand on the pulse, a little pressure on the shoulder, or a little pressure underneath the chin. You get the patient to push down on your hand, so their scalenes are contracting. Big breath in, hold the breath, feel whether the pulse goes or they get any symptoms or signs in the hand. Adson's test. Falconer's test is the military brace position. So you get the patient to get both arms back. You take their arms behind them, like that, and you feel their pulse pulling down on their arms at the military brace position and seeing whether or not the pulse diminishes. Naricus's test tests the pulse with the arm abducted in that position. Again, here the subclavian vessel passes through, goes around the hook of the coracoid and then down the arm, and so it can be compressed at that level as it goes underneath pec minor. So that's Wright's, Adson's, reverse Adson's, Falconer's. You want to distinguish whether or not an element of this is coming from the neck, and so you do Sperling's test, and you then put axial pressure on the head, and if you shift it one way, then you're creating brachial plexus tension down this side. So if that's positive, then you know it's a brachial plexus tension problem. Whereas if you then shift the head this way, you're closing up the foramina through which the roots escape, and so this will be positive in radiculopathy. So if they're positive when the head is like this under axial pressure, it's a radiculopathy, not a plexopathy. There's another test called cervical rotation lateral flexion test, where you rotate the head, the neck, and then flex it forward. And you compare that to rotation and flexion the other way, and on the affected side, there's diminished lateral flexion after rotation, said to be because there's some slippage of the first rib down its origin, and it blocks lateral flexion after cervical rotation. Of course, you do the normal range of neck motion, lateral flexion and extension and rotation. The other test you do is Roux test, which is a non-specific sign where you put both hands up like that and their arms held up, I surrender position, and get them to open and close their fingers, and you see that David's hands are going very white. So here's a positive Roux test. That's an indication for an operation. No, it's not. It's cold. But it's just cold. So that's a test, and I remember that because the kangaroos surrender before they get shot. So that's Roux test. And so those are the vascular tests that I do, and then the remaining test I do is Morley's compression test, where I palpate the clavicle, feel the interscalene groove under the cover of the sternomastoid, and put some light pressure on the plexus. Now, if that pressure on the plexus provokes symptoms, neurological symptoms or vascular symptoms down the arm, then that's confirmatory that the problem is thoracic outlet syndrome on this side. At the same time that I'm doing that, my thumbs are feeling the posterior elements of the vertebra in order to confuse the patient in case they go, oh yes, for anything you palpate. On that occasion, they'll say, oh, the back of my neck hurts, rather than where your fingers are here. You can also put local anesthetic into the scalenes to see if that changes the symptoms. That's how to examine the thoracic outlet in addition to doing your your neurological examination of the upper limb. For arm movement, so shoulder abduction is C5, elbow flexion is 5 and 6, elbow extension 7 and 8, wrist movement up and down, pronation and supination is 6, wrist movement up and down is 6 and 7, finger movement up and down is 7, 8, and of course finger abduction and intrinsic muscles are T1. So they give you a rough guide as to what's going on, and there's certain indicative muscles that are a bit more helpful for particular routes, like brachyradialis for C6, for example, deltoid for C5.